Health Administration. Her research centers around the theme of developing and applying rigorous analytic methods to inform policy and resource allocation decisions relevant to older adults. She's a senior associate editor at Health Services Research and is a member of the Medicare Evidence Development and Coverage Advisory Committee and the Federal Interagency Council on Evaluation Policy. Dr. Garrido received her PhD in Health Services Research, Policy and Administration from the University of Minnesota, Twin Cities, and completed an NIMH postdoctoral traineeship in mental health services research at the Institute for Healthcare Policy and Aging Research at Rutgers University. She's published almost 100 papers in well-regarded peer-reviewed journals and has funding for her research from the NIH, foundations, and the VA. She leads a large VA query program on policy evaluation and other projects on heterogeneity of treatment effect timing in geriatrics and palliative care. And I think you will find this very interesting, a bit different from some of the other work we've heard over the years. And I think she brings some new life into the department in terms of, if she were to come here, some new areas for us to think about. Listen, and also has background in aging, which is when I met her in the Department of Geriatrics. It wasn't palliative medicine at the time, was it?
It was geriatrics,
It was?
palliative medicine.
Okay, that was maybe 10 or 12 years ago at Mount Sinai.
Thank you for that introduction, and thank you all for the invitation to be here today. I'm going to talk about some of my work on optimizing coverage and care for older adults. Get the disclosures out of the way. I have nothing to disclose. Any views that are expressed in this presentation or any errors are mine and mine alone. I also do want to acknowledge support from the NIH, Commonwealth Fund, Arnold Ventures, and VA for the work that I'm presenting today. And the work that I've done is certainly not been in isolation. I've listed my co-authors on the slide for the work that's included in today's presentation. Just to expand a little bit on my background to provide some context for the work I'll be describing today. So my PhD is from the University of Minnesota in Health Services Policy, Research, and Administration. I have a minor in gerontology. Bob and Rosalie King were my advisors. Then I moved on to Rutgers, where I did a postdoc at the Institute for Healthcare Policy and Aging Research. And from there, I joined the Geriatrics and Palliative Medicine Department at the Icahn School of Medicine at Mount Sinai. And I also joined the VA as an investigator at the Bronx GREC. So I'm still at the VA, but now I'm over at the Boston VA at PEPRAC, which is the Partnered Evidence-Based Policy Resource Center. And I'm also at BU in their School of Public Health in the Department of Health Law, Policy, and Management. So all of the work I do in both the university and on the VA side, I really have a focus on evidence-based policy. And just to kind of set definitions here, evidence-based policy includes first, just having support for using evidence, making sure that the need for evidence is valued in the decision-making process. It also includes identifying gaps in the evidence base. So this isn't just researchers sitting in isolation thinking deeply about what the gaps are. This is working with stakeholders to understand what are the gaps that are important to them. What do they need to know in order to move budgets or policies forward? Next, it includes rigorous systematic use of evidence. So you want to make sure that folks aren't going to just cherry pick the good results that match their priors and ignore anything negative. And then ideally, this will all lead to informed decisions about a policy or a program. And this is an iterative policy. As you can imagine, most policies and programs can continuously benefit from some improvement. And so for public health, the evidence development, some of the inputs into this cycle, it can come from a range of different disciplines. It can be epidemiology, it can be health services research, health econ, clinical research, et cetera. And the gaps can range from identifying the scope of the problem, so characterizing the breadth of a problem, or it might be developing evidence on how to best address that problem. Or maybe creating a budget impact analysis and cost effectiveness analysis about the most financially prudent way to address a gap. And then underlying all of that is using rigorous causal inference to make sure that you understand that the intervention or the policy that you're studying is actually leading to the outcome that you want to make an impact on. So I'm not going to talk in detail about this first box today. That's an entirely other talk. I could go on for hours about that. But I'm happy to talk to anybody offline about our efforts to do that within the VA. So the center I run, we play a leading role in VA's response to the Evidence Act, which requires that all cabinet level agencies use evidence to support budget and policy decisions. So what I'll focus more on today is, identifying the gaps in the evidence and using it to inform decisions. I'll talk about 3 different aging-related projects, 1 in the VA and 2 outside of the VA. And then as well as some work on improving researchers' abilities to conduct rigorous policy-relevant evaluations. So first up is the Veteran-Directed Care Program. So this is a participant-directed care program, the goal of which is to keep people out of the nursing home and in their home if that's where they prefer to be. People who are eligible for this program are generally eligible for about 20 hours or more of home care a week. And they receive a monthly budget to purchase the services or supports that they need to be able to stay at home. So this could include paying for home health aid from an agency. It could include paying for a family caregiver to stay home with them. Or it might include making modifications like wheelchair ramps or installing grab bars in the home. So there's a wide range. And there were promising early reports of the success of this program. In interviews with veterans who were part of the program, they really enjoyed it. Some called it life-changing. And there were some initial quantitative studies, but they were limited to just a few small sites, and they didn't control for selection into treatment. So when this study started, the VA Office of Geriatrics and Extended Care, they really wanted to develop some rigorous evidence about the impact of veteran-directed care on trajectories of hospital use, nursing home use, and costs. With the idea being that if their hypotheses were supported, they could use this to expand veteran-directed care throughout the nation. And if their hypotheses weren't supported, they would use this to maybe direct their resources elsewhere. So this slide shows the objectives of the evaluations. We wanted to determine the extent to which vet-directed enrollment was associated with reduced inpatient admissions, emergency department visits, and nursing home admissions. We also wanted to look at the extent to which vet-directed enrollment was associated with reduced costs associated with inpatient admissions. And then finally, we wanted to understand if outcomes differed for users of vet-directed care who reside in rural versus urban areas. With the idea being that in rural areas, it's much harder to have access to things like home health aides. So in our sample, we looked at a little over 37,000 veterans receiving at least 1 VA purchased care service. This is one of the older studies I'm talking about today. So this was in fiscal year 17. We looked at 38 medical centers. So we had 3 different comparison groups. One was the group of people receiving veteran-directed care. There are only about 1,000 of them in this group. And then we looked at recipients of other purchased care services, so contracted adult day health care, caregiver respite, or home health aid programs in medical centers with vet-directed care programs, trying to control for site-specific differences in care for older adults. But then we also looked at recipients of other purchased care services in medical centers that did not have a vet-directed care program, because we wanted to control for potential systematic differences in who was referred to vet-directed care in the sites that did have the program. We only used a subset of sites without vet-directed care programs because we were fortunate to have a list of sites that wanted to institute a vet-directed care program, but just hadn't had the chance to yet. We originally had lofty goals to do this in a randomized trial that fell apart in spectacular fashion. But we pivoted and used this for an observational study. So we used a triple differences approach. So we looked at differences in outcomes from before to after initial enrollment in vet-directed care, compared that to trajectories of outcomes for people in the other purchased care services, and again stratified by urban and rural locations. So what did we find? When we looked at everybody all together, which is not on the slide, we found similar trajectories of hospital use and costs over time when we combine the rural and urban enrollees. We already were encouraged by those results because the people in the vet-directed care program actually are more severely ill than the people receiving the other purchased care services. So despite being more severely ill, they had at least as good of outcomes. But when we stratified by rural and urban status, we found that rural vet-directed care enrollees actually had fewer acute care visits over time compared to enrollees in other purchased care services. We saw a similar pattern with ED visits as well. And then when we looked at VA nursing home use over time, we found that both rural and urban vet-directed care enrollees were less likely to be admitted to a VA nursing home than people in the other purchased care service programs. So we saw the greater benefits of vet-directed care for rural versus urban enrollees. So we think the flexibility of the vet-directed care program might be especially beneficial for rural veterans. And our kind of overall conclusion for this project was that VDC is a valuable option for supporting veterans with multiple chronic conditions and their caregivers. And one of the really exciting things about this study is that the results were immediately used. So the VA used citations from our studies to respond to reports from the VA's Office of Inspector General about the need to expand on long-term services and supports in the home and community within the VA. It's also been cited in the GEC strategic plan, and it was used to support expansion of vet-directed care nationally. So right now there's a mandate to expand this program nationwide in the next year or two. The exact deadline keeps changing. We've also fed back the results to the Administration for Community Living, which helps administer this program. That's where the No Wrong Door logo is from. So we were able to present the results to the sites that were actually running the programs or thinking about starting a new program. And we're still doing work in the space. So we now are looking at the impact of vet-directed care on days at home, so incorporating measures of non-VA care as well as VA care, with the idea being that more days at home should be preferable. And we also want to better model selection into vet-directed care so that we can account for time-varying characteristics that are associated with both vet-directed care enrollment and with outcomes over time. Before I go on to the next project, I'm happy to pause and ask or answer questions. I forgot to mention, if folks have questions, feel free to shout them out.
One of the things with these types of programs that I always struggle with when you match comparisons are what's the dose that they're getting, right? Because you usually have to say that they touch the service, yes or no, but it's the people that actually touch it and then use it meaningfully. How do you account for like dose of services use when you look at such like multi-component programs and which pieces actually work?
That's a great question. For the vet-directed care treatment group anyway, we did look at different definitions of dose. So the results I presented are just any interaction with the vet-directed care program. But we did run sensitivity analyses where we made sure people were interacting with the program for multiple months, and have to look up the exact details, but we saw similar results. And we should probably go back and do that for the other purchased care services as well.
So if there's similar trends and people who use it a lot versus people who just touch it once, are they the same people? Right? Is there like a selection issue?
Yeah, and I think that's something that we need to look into more. And one of the things my team is doing now is trying to just understand what are the patterns that people are using. So, people who are in vet-directed care, many of them are also still receiving home health aid services too. These services aren't provided in isolation, and they're often given in a staggered manner. So I agree with you. There's a lot of nuance and different ways that we can look at it.
Usually challenging. It's really cool though.
I have an easier question.
All right.
Can you explain how you collected the outcome data and what VA national data you were using?
Yes, I skipped over that part. I apologize. We used corporate data warehouse information on inpatient admissions, ED admissions, all within the VA system, and VA nursing home admissions. We didn't include contract. I think we included contract nursing homes as well.
Thank you.
So you didn't do outside the VA then?
No, not for that particular study. But we at least had the same information for everybody. So yes, we are missing information on outside of VA trajectories, but we were looking at the trajectories within the VA and comparing those. All right, so moving outside of the VA, some other work I'm doing is looking at the State Health Insurance Assistance Program, or SHIP program. And if folks have not heard of the SHIP program before, this is one of the ways that Medicare beneficiaries can receive counseling about the different coverage options. So there's 1-800-Medicare, there's Medicare.gov, and then there's SHIP. SHIP is unique in that the operations of the program vary by state. So Administration for Community Living provides grants to all of the states, and then they sub-grant funds out to other community organizations, so things like AAA's or health systems. There's a wide variety. And the SHIP program has been called out as a potential way to combat misinformation from deceptive advertising of Medicare Advantage ads. So it's received a lot more attention in recent years. And understanding ways to get this navigation support and looking for opportunities to improve the navigation support, I think it's more important than ever. Enrolling in Medicare is increasingly complex. The average Medicare beneficiary has 43 Medicare Advantage plans they could choose from. That was as of last year. And it's even more complex for dually eligible individuals who can enroll in both Medicaid and Medicare. And part of the SHIP program funding is also based on the number of low-income beneficiaries in a state. So we have people in the Senate calling for more individuals to use SHIP, but we don't know if SHIPs are actually reaching the populations that they're meant to serve. The existing data on the SHIP program are at really high levels. So the ACL does produce some metrics that they report to Congress, but they're at the state level. They focus on the number of people served in a county, or in a state rather. So what we did, and this is with support from Commonwealth and Arnold Ventures, is we decided to try to characterize the service areas of SHIP counseling sites and understand if they are comparably located in higher and lower income localities. And then, proximity to services is one metric of access, but that's certainly not sufficient for access. So within places where we know there are SHIP services, we've identified barriers to and facilitators of SHIP service provision to low-income beneficiaries. And this is through interviews with SHIP counselors and coordinators. And then the last piece of this project is determining whether SHIPs have the knowledge and expertise to actually answer questions correctly about Medicare coverage options. That piece is still in progress. We're using mystery shoppers who call up different SHIPs and go through a script and ask a bunch of questions. And I can't wait to see what the results are. We're already finding some difficulties even reaching SHIP counselors. It's going to be interesting. So going back to the first objective, so we used web-based information, just kind of a web scraping exercise to gather information on the localities of the SHIP site across the nation. So we had to use state-based SHIP directories as well as some information from ACL records on who the sub-grantee organizations are. And what we found is that the availability of information really varies by state. So I focused on the counties that are highlighted in blue shading here. Some states only list a 1-800 number, and other states will only list the area agencies on aging, which we've learned from our interviews, usually are sub-granting out to another organization that's not the actual location of services. So we focused on these 27 states that had some web-based information. And what we found is that more than half of the localities did have a SHIP site within the county. About a quarter didn't have one within the county, but did have one in the adjacent county. And then 13% didn't have a SHIP site accessible anywhere within a county or adjacent county. Note that localities here refers to zip code tabulation areas. And I'll also note that SHIP services are available by phone and via Zoom, but the in-person services are especially valuable. People without a computer or who are not comfortable using a computer often prefer to come in person because it's a lot of information. Trying to just input all of that over the phone is really difficult. And similarly, a lot of dually eligible beneficiaries want to come in person because the options are so complicated. So great, we see that more than half of localities have a SHIP site within the county, but what we did find is that there were disparities in the areas. So the population living in ZICTAs without in-person SHIP sites is more likely to have low income, they're more likely to have fewer years of education than the population living in ZICTAs with a SHIP site. So income depicted here on the screen. We did not see a significant difference in Medicaid or means tested coverage prevalence between sites with and without a SHIP program. But the difference in income levels suggests that there are people who are eligible for things like low income subsidies or Medicare savings plans that might benefit from some additional navigation services. So there might be a rationale to expand SHIP services or other navigation supports. So we also looked at, as I mentioned, at barriers and experiences of providing services at the sites that do provide services. So we interviewed 22 SHIP counselors and coordinators from across the nation. We had support from ACL to do this, which was great because we had to try to figure out how do you get to the counselors and coordinators at all these local sites. So we presented on a nationwide call to all of the state SHIP directors, told them about the study, prepared them, and then emailed state directors that had the site within their state that we wanted to talk to and asked for them to provide outreach. And we did a stratified random sample, so trying to get a range of urban and rural sites, low and high income, and so on. So low income beneficiaries, the topics relevant to them came up quite frequently. So Medicaid, just costs of coverage, and dual eligibility are some of the most frequently discussed topics. A lot of people come in and end up talking about things like Medicare savings programs or low income subsidies. They don't necessarily know what those programs are. So a lot of the counselors talked about the importance of screening everybody who comes in to see if they're eligible for the program. Other common topics were redetermination of Medicaid eligibility for enrollees nearing 65. And then because of the timing of our interviews, which just happened last year, a lot reported issues talking to people about the unwinding of Medicaid benefits due to the end of the public health emergencies. We're getting several calls about that. Another common topic was correcting misconceptions from advertisers or brokers. People would come in, think that they saw a TV ad that was advertised broadly, but it wasn't available in their county. That's kind of the more innocuous case. In other cases, the ads are really misleading and promise you, the moon and the stars, and they would come in and talk to a counselor and kind of be brought down to earth. One referred to backing them off the ledge before they made a choice about an MA plan. And in some of the most complicated cases, people would end up on an MA plan that they didn't want. In one case, they already had Medigap, so the counselors would work with them to try to disenroll them from MA when that was possible. So they're providing a lot of really useful information, but we did find a couple of barriers that were consistently reported. One was the availability of volunteers. It's really hard to recruit people who are willing and able to provide counseling on Medicare coverage options. I'll say as an aside, I'm trying to help a family member enroll in Medicare and I'm having a difficult time parsing through the options. So they look for people who have backgrounds in insurance or health. And who have the technical skills to be able to provide this information to people. It's rigorous training, it's time consuming. A lot of volunteers quit during the training process. Once they make it through training, then retention is pretty high, but it's a steep road to get there. And then relatedly, the complexity of information itself is a barrier. A lot of counselors said that they wanted to have more training in Medicaid, and dual eligibility was mentioned as one of the most complicated topics they had to deal with. And I'll say that we had a few concerning statements from folks that suggest that there might be some additional opportunities to improve training. In one state where dual special needs plans were available, the counselor was mentioning that just a plain old Medicare Advantage plan is usually best for their dually eligible population, which is unlikely to be true. The most concerning case, someone mentioned that they were getting training on MA from YouTube videos created by insurance brokers. So there's a little bit of baseline training that we might need to do there. So far, what we think is that additional counselors and increased training on topics relevant to dually eligible individuals might improve SHIP's ability to provide health insurance related information to low-income Medicare beneficiaries. And there might be areas where it's worth expanding in-person SHIP service expansion. Although depending on what we find from our mystery shopping, we might add a little bit more nuance to that last bullet. So this project is still in progress, so the dissemination and impacts are still in progress. But I think it's a good example of kind of the iterative nature of policymaking. So I was able to talk to staff from the House Ways and Means Subcommittee on Health. They had a lot of questions about the SHIP program. I presented an earlier version of these results to them. And they came back with just a whole list of questions. I have a research agenda right there. One of the questions was just, if we were to get more money for the SHIP program, how many more beneficiaries could we serve? So I was able to go back and do some back of the envelope calculations on that from my web-based directory study and get that information back. They also want to understand how counselors help beneficiaries make decisions between Medicare Advantage and traditional Medicare. And that I'm going to feed back the results from the interview study, which I just submitted the paper last week, and then incorporate our mystery shopping.
General question, how do you evaluate the quality of the help and advice that people are given?
That's a great question, and that's the part that's still ongoing. So through our mystery shopping, we have a script with specific questions, and we've added or made a point system so that we can actually explore people. Not only are they providing the correct information, but how complete of information. Because you can, make one statement about the differences between traditional Medicare and Medicare Advantage. It might be correct, but you might be leaving out a whole host of important information. But yes, that part's still in progress.
There's a lot of new research coming out about selection into Medicare Advantage and Medicare fee-for-service based on patient needs. Like patients living with disabilities or frailty, are much more likely to disenroll from traditional Medicare and our Medicare Advantage into traditional Medicare fee-for-service. So do you have information about disability or function or other kind of needs for these patients? Because I know there's been a lot of concerns about high needs Medicare beneficiaries that are on Medicare Advantage programs and having a lot of unmet stuff going on.
Yeah, unfortunately, I don't have data on the beneficiaries' characteristics. All of this has been from the kind of the program operations side. But that's something that I do want to do in the future is, understand, what are the needs of folks who are seeking these services or other services? Do people even know that these services exist? And then if you interact with the SHIP program versus, say, a broker, is that going to impact the quality of the decision you make? Are you going to make the best decision for you about your coverage?
So I wondered, did the SHIP counselors, do they ask about things like disability or functional needs? Because I wonder if that actually drives some of the advice, good or bad.
I'm trying to recall, they didn't explicitly talk about asking about disability, and I meant we didn't ask that either. They talked more about screening by income. They did mention sometimes people weren't able to go to a SHIP site in person, sometimes because they were homebound, and then they would go out to those people and provide home-based counseling services. I think the only ones that came up were vision or hearing disabilities that might impact the quality of communication with the SHIP counselor, but that's something we should look into in the future. It's a good idea. Other questions? All right. So now for something completely different, but still about Medicare. Some other work that I'm doing is looking at the impact of network breadth, network size on access to and quality of care for Medicare Advantage beneficiaries. So in MA plans, usually networks are formed with the idea that a plan can contract with providers that they think are going to provide higher quality services and hopefully at reduced cost to the insurer. But there's concern that if the network is too small, then people aren't going to be able to access needed care. And it's been really difficult to understand whether this is an issue. There have been studies about network breadth and quality and access to care, but they're based on directory data. And if you've ever tried to look for information on whether your own doctor is covered by an insurance plan, you know that they're often wrong. They're outdated, they're just incomplete. They don't tell you if a doctor is accepting new patients. So it's been the best that we could do. But we've tried to improve upon it by looking at measures of observed interactions with doctors in a given area based on Part D data, so looking at prescription drug encounter data. So here, this is an RO1 that's led by my colleague Austin Fracht. I'm a site PI in the study. We developed a measure of observed MA network restrictiveness and then looked at the extent to which network restrictiveness is associated with both plan quality and beneficiary cost. So I'm calling it network restrictiveness rather than breadth, which is the term that's usually used in the literature. Because in the literature, they're talking about potential networks. So assuming that the doctors are all available, all accepting new patients, if the directories are correct, that's the potential network that people can observe. We're basing it on observed encounters. So what we do is we compare the number of unique primary care providers that are seen by Medicare Advantage enrollees to the estimated number of providers that enrollees would see if all providers were in network. We obviously can't observe that denominator on the counterfactual, so we estimate it based on traditional Medicare beneficiaries. So to do that, we model the relationship between the number of providers who are seen by traditional Medicare enrollees with prescription drug plans and the number of enrollees, the number of prescription drug events, state indicator, number of providers prescribing to beneficiaries, average age and mortality rate. We do this all with a random forest model. And then we use this model to predict the number of providers expected to be seen by MA enrollees if there were no network restrictions. I'm skipping over a lot of gory details about model tuning and validation, which happy to talk about later. They're also in a recent HSR article that was led by one of my former PhD students. So we've got this new metric. So what can we do with it? So first, we tried to look at the relationship between MA network restrictiveness and star quality ratings. Star quality ratings are what beneficiaries have available to them to make a decision about a plan. But we know that star quality ratings they're aggregated. So it's not clear if they're going to be super useful for making a decision or if they'll be reflective of changes in one small feature of a plan. So we also looked at CAHPS measures of access to care, so things like getting access to needed care, being able to make appointments, and so on. So we did not find a relationship between MA network restrictiveness and quality. This is the star ratings here on this graph. But we also did not find a relationship between MA network restrictiveness and the other access measures. So the star rating issue, we think it might just be because we're looking at these aggregate measures, and there's an existing literature about the limitations with the star ratings. For the access measures, we're not sure if it's again an issue with the access measure. It's survey based, so maybe that's part of the issue. It's not a representative sample, or if the differences we're seeing in network restrictiveness are just too small to be meaningful and to be reflected in these types of metrics. So going forward, we're going to tie our measure to claims-based measures of access and outcomes. So looking at things like preventable hospitalizations, for example. So this evaluation work is still in progress. We still have to look at costs. So we also are planning to, I'm going to submit an RO1 in the fall that extends this work. We're going to move on from using Part D data to encounter data. Encounter data weren't available when we first submitted this proposal. So then we can make sure that the patterns that we see when we're looking at prescription data actually apply to people who are seeing a variety of providers. And then we also plan to include subgroup analyses looking at people with ADRD, frailty, multimorbidity, to understand, if there are any important differences, how big are they for these populations of interest. So and our eventual customers for this work is, again, it's still in progress, are CMS. They want to regulate network adequacy, so our results would inform that. But also the beneficiaries themselves. So, star ratings aren't useful for understanding differences in provider availability. So maybe there's other metrics we might be able to develop. Before I go on to the next part, are there any questions? All right, okay. So changing gears a little bit from talking about specific program or policy evaluations, I want to talk briefly about some of my work in methods. So I do a lot of work focusing on selection into treatment or confounding by indication and trying to understand how to improve researchers' abilities to use administrative data to make rigorous inferences about treatments or policies. So there's two projects I'll touch briefly on. One is an older project where we did some work to understand when choices of propensity score estimation and weighting or matching strategies lead to divergent inferences in analyses of categorical treatments. And the second is some ongoing work where we are looking at when choices of weighted difference estimation strategies, when do those matter when we have an analysis with a staggered treatment timing scenario. So I started looking at categorical treatments when I was realizing that most of the guidance for how to develop propensity scores focuses on binary treatments. We know that not all treatment decisions are very binary. There's a lot more nuance than treated versus untreated. So I focused on categorical treatments, just as a kind of motivating example. Think of a hypothetical study that's comparing self-directed care, home health aid services, and adult daycare on nursing home admissions. So if we're using a binary propensity score, we have a couple of options. One is we just dichotomize the treatment, but we know that's going to obscure some important between group differences. So we look at self-directed care versus the other two, or home health aides versus the other two, so on. The less recognized issue is when you want to make pairwise comparisons among specific treatments and then compare them to each other. So say you run an analysis of self-directed care versus home health aid and adult daycare versus home health aid, and you want to compare those two inferences to really make a decision about which of those three treatment options is best for an individual. That's when there are some issues. So what happens is that you have to really restrict the sample you use to create a propensity score if you want to make inferences across an entire set of different treatments. So looking at a comparison of home health aid and self-directed, if you're only focused on those two, you're going to look at the intersection between the pink and the blue circle. If you're looking at home health aid versus adult daycare, that would be the pink and the green circles. But then you're using different populations to generate these estimates. They're not directly comparable. So you really want to focus on the intersection of those three circles. So to do this, you can use a generalized propensity score, it's probability of receiving one treatment level or option conditional on observed covariates. So you're estimating your propensity score if you're using a parametric model from a single multinomial model, and each level has its own propensity score. Just a bit of jargon, the vector of propensity scores is a set of an observation's estimated probabilities of receiving each treatment option. But where weighting and matching strategies differ is in how much similarity of vectors of propensity scores they require. So in non-vector based methods, so these include inverse probability of treatment weighting, which we all know it's in every statistical package. It's very popular. This includes generalized propensity score matching. It doesn't require matching on the entire vector of propensity scores. It requires matching on the probabilities of two treatment levels and the non-zero probabilities of the other treatments. In vector-based methods, vector-based matching existed when we started the study, and then we developed this vector-based kernel weighting. We require similarity on probabilities of all treatment levels, and then this enhances your ability to make direct comparisons of pairwise treatment effects that are derived from the same sample. This is just a way to depict it rather than in words. So the idea is that you're going to make your treatment and your comparison observations look as similar as possible on the probabilities of receiving any of the treatments. So we did a giant simulation study, details of which I will not go into here, but we looked at 4,500 different analytics scenarios, different things you might encounter as an applied researcher. And what we found is that estimates based on inverse probability weighting were more likely to be biased and inefficient than estimates based on vector-based kernel weighting. So as a way to kind of give practical guidance to investigators, we looked at the number of scenarios in which there was relatively low bias. Just, on average, how often does it make a difference which method you use? And in our vector-based kernel weighting method, in almost every scenario, we received an estimate with low bias. That only happened in 37% of the cases for inverse probability of treatment weighting. We also found that inverse probability of treatment weighting is much more sensitive to propensity score misspecification than vector-based kernel weighting. And this is an issue because we don't ever know if our model is truly well specified in real life analyses. Chances are it's probably wrong. So the vertical line here is 0 bias, and the dark blue line, which is centered here on the top panel of the graph, that's the fully saturated propensity score model. So the one in which we know that the model is correct. Then the inverse probability of treatment weighting did okay. But in all other cases, there was quite a high degree of bias. Where in vector-based kernel weighting, we were able to center the bias around 0. So this isn't a normal policy study with an impact, but what we did do to try to improve the reach of our work is created a stated command. It's available in SSC to use VBKW for categorical treatments. And now what we're trying to do is apply VBKW to other complicated analytics scenarios. So what we're doing now is jumping into the thorny world of staggered treatment timing. And just to give an example to kind of orient you to the issue, think of a hospital system that wants to roll out a new flu vaccine clinic in their outpatient clinics. They get to choose when they start the date. The idea is to set up a new walk-in clinic program, and the outcome is vaccine completion rates. So we might have treatment effects vary with time for several reasons. One might just be seasonality, so prevalence of flu changes throughout the year. It could be other delivery system changes. So maybe halfway through the year, the hospital system rolls out a new masking initiative that interacts with the flu vaccine clinic program. All of the clinics will experience changing treatment effects with duration as they gain more experience. They're going to probably be able to vaccinate more individuals. But the one that I'm really concerned about is selection into treatment timing, so early versus late adopters. So you might have clinics that have had previous experience with a preventable care campaign that are really gung-ho. They decide to do the program right away, and they expect that they're going to have success, and then they do realize that success. But you might have some late adopters who either have not had great success with this kind of program before, or maybe they have a lack of resources or available staff, and so they wait till the last possible minute to adopt the program. So with that kind of scenario, if you are looking at your average treatment effect among the treated, and you're looking separately among your early adopters and your late adopters, you might see wildly different estimates. So you might see a 40 percentage point increase in vaccine rates in the early adopter group, and you might see only a 2 percentage point increase in the late adopter group. So it's unclear just from those numbers, what's the most useful metric to give to policymakers? So what we want to do is isolate the impact of the treatment from the impact of observable factors that are associated with both early or late adoption and the observed outcomes. So what we're doing is another simulation study. This is funded by the VA, where we're looking at developing best practices for addressing confounders associated with both treatment timing and outcomes. So we're comparing bias and efficiency of estimates from two-way fixed effects models with different weighted difference in difference estimators. And the way that VBKW gets in here is that right now the most popular weighted difference in difference estimator is one created by Callaway and Santa Ana. It is a series of binary comparisons using IPTW. So we thought, well, maybe VBKW will also outperform IPTW in this case. So far, our results don't suggest that that is the case necessarily. They seem to perform pretty much similarly. But what we do show is that these weighted difference in difference methods are useful for accounting for the influence of factors that are simultaneously associated with early adoption of a treatment and outcomes. And that's something that currently these estimators have not been used for widely. All right, I've talked a lot about a lot of different projects. I want to briefly talk about kind of looking forward, what do I want to do next in all of these areas. I do have short and long-term plans for extending all of the projects in these areas. For the Medicare policy, for example, I'm submitting that R1 that I mentioned in the fall to include encounter data and to also include some claims-based measures of access to care. For consumer protections, I've had some preliminary talks with Commonwealth Foundation about extending our current work to understand, the impacts of decisions, or the impacts of going to a broker versus a ship on insurance coverage decisions. They've shown interest, but of course, they're not going to commit until I make it further into my existing funded study, which is fair. But thinking a little bit further ahead, I think there's a couple of exciting ways to kind of bring this all together into a more cohesive program. Can think of kind of two different approaches. One would be creating kind of an evidence-based aging policy center that includes all of these buckets on the screen, and trying to kind of expand the different policy research ideas that are created under each of these topics. For example, you might look at what's the best way to allocate resources to home and community-based long-term services and supports, do kind of simulation study. Within Medicare policy, we might expand the network extent work to look at the impacts of network extent on outcomes for dually eligible beneficiaries. But I think a potentially more exciting way to look at all of this work would be to kind of do a deep dive into one bucket at a time and focus on a more translational approach. So, focusing on, doing some epidemiologic foundation studies, developing an intervention, then adding a research aim looking at the cost effectiveness or budget impact of the intervention and figuring out what's the policy impact or what's the best way to design a policy or a program to ensure that there's uptake of the program. So you might, building on hip fracture, for example, might try to understand the needs for home-based care for people with hip fracture. And then you might do a simulation study to understand which method of long-term services and supports is most cost-effective in that population. And I've been fortunate to talk to many of you today already. I'm going to be continuing to talk to folks today and tomorrow, and happy to continue talking about those ideas as we go forward. I'll leave some time for additional questions if anybody has it, and thank you for your time.
It's a great talk. Really wide breadth of information and knowledge. Ask us a stupid question about differences just from a more, I guess, education point of view. So I'm an infectious disease researcher, and I got my MPH. We learned nothing about the quasi-experimental design, just used extensively in like quality improvement projects. And Larry and I have been using differences in quasi-experimental design. The method you were talking about with the kernel aspect apply to that type of design? Because I guess my question is one, and B, do they teach any classes on quasi-experimental design? Because it seems like it's used in HSR&D all the time, health services, but not really taught as part of a core, PhD program and stuff. And if so, kind of what textbooks are you using to teach that?
Yeah, great question. So first, the kernel-based method I talked about, you could apply it to a difference design, and that's what we are doing in that second study. So trying to, the idea is to make the early, middle, and late adopters look as similar as possible, other than the receipt of treatment. So kind of taking away the treatment timing aspect. As far as teaching, I'll admit I'm not involved in the curriculum at BU. I'm a research professor, but I do know that we teach our PhD students about differences, propensity scores, instrumental variables. I don't know what textbook they use, but I know Scott Cunningham has a great free one that I go and use when I need to go look up something and I just have a mental blank and need a refresher on that one. That one's useful.
Thank you.
One of the things I'm reading a lot about and people are like proposing as innovations is I did emulated trials, for testing some of the things we talked about. And we have researchers here doing it with different diabetes drugs. We've talked about doing it with some rehabilitation stuff before surgeries. But how do those kinds of methods, which generally draw from like propensity scores to match the treatment groups, like are those methods that you see as valuable, or your refinements that you're making, would those kind of help strengthen some of those emulated trial methods that are becoming a lot more popular?
Yeah, I think they'd be directly applicable because as far as I can tell, honestly, emulated trials are propensity score methods. I actually tried to put in emulated trials in a R03 application and all the reviews came back, that's just propensity scores. They're like, stop trying to dress it up. But maybe there's more nuance that I'm not appreciating, but yeah, I think these methods are directly applicable.
So I'm trying hard to get my head around the kernel-based weighting or the vector-based kernel weighting. So in a situation where the exposure is categorical, is the bias introduced by using inverse probability of treatment weight only in a situation where you're doing this three-way difference in differences? Or is it introduced at any time when you are using inverse probability of treatment weights with a categorical exposure?
Yeah, I think it's really only when you're trying to make that three-way inference when you want to expand beyond that pairwise. But I will say in just in a binary treatment case, I still think kernel weighting is useful to explore over inverse probability of treatment weighting. I realize I skipped over that maybe critical piece of explanation is that kernel weights don't use the entire scope of a distribution of propensity scores. They'll focus on the propensity scores within a bandwidth of the treated observations propensity scores. So they're not as susceptible to extreme weights. So that's where I think there's still benefits.
So they are, that's what I was wondering, is if they were essentially throwing out data in a way, throwing out observations at the ends of the distribution. But the inverse probability of treatment, if you're using it as a weight, it's not doing that.
Yeah, and with either of these weighting methods, you're not throwing out observations, you're just diminishing the weights that you give them.
You mentioned a scenario where you had significant baseline differences in your groups, and this method, you kind of had said you'd done that as a sensitivity analysis, and that's where we've struggled with some of the surgeons that I'm working with, is that they have two different people who get a different type of surgery, but the indications for those surgeries might be very different. So the populations at baseline are much sicker that get this more, traditional surgery. So the recent methods of advice have been overlap weighting, where you basically force the groups to be exactly the same by assigning them the probability of the opposite group. But that seems to kind of, condense people down. I don't understand how that concept is different than some of this more, what sounds like a little bit more analytically complex kernel-based weighting. Do you have a sense of how they compare?
Yeah, I don't have a sense of how they directly compare. And, I think with any of these methods, a good strategy is try a few different weighting methods. If you get a different answer based on what weighting method you use, I wouldn't be too confident in it. We're also doing a lot of comparisons with entropy balancing, which feels like it's too good to be true sometimes because you get the perfect covariate balance. And what we found is in the cases with extreme imbalance at the outset, entropy balancing will just fail to converge, where we can still use vector-based kernel weighting and it's still able to get a reasonable estimate. It might not be the best one, so it might not be the best approach.
I have a question. So if you had a couple of different, your last slide talked about going in a couple of different directions. One sort of a broad policy perspective where multiple things come together. The other is taking a deeper dive into one or each of these. In relation to taking a deeper dive, most of your work seems to be with sort of large databases and using existing data. Could you envision a connection to individual data collection where you get more closely into the functionality or the disease state, other than enters in the coding systems that that wind up in the larger data systems. Can you see any connections there or potential either for yourself to do that or to bring other aspects of that work into this broader array of work?
Yeah, absolutely. I think there's a really good opportunity to, start with that more granular individual level data collection. So either, one-on-one intakes with patients or, testing and intervention with folks, or maybe doing a survey or a cohort study. And then using that to really understand what are the needs that need to be met and what's the intervention that's going to address those needs. I think the secondary data comes in kind of later in, okay, how do we pay for this, or how big of the problem is it nationwide, so to kind of expand beyond what you're able to find in a more granular study. But I think any study is usually improved when you come at it from a couple of different angles.
So to sort of follow along on Jay's comment. So the whole time I'm thinking, well, this could be really powerful for looking at things like disparities, looking at vulnerable populations. So more of a narrower scope, right? So a patient specific, like a disease specific analysis, or like fracture, other things that we do here, rather than, it's overall community-based services, but maybe it's within a specific population. ADRD, there's lots of money available now. So do you see sort of value in doing this type of research, but in a more narrow scope?
Yes, absolutely. And I think that would actually improve our ability to make inferences from analyses. So some of the work I do, like the Medicare Advantage Networks study, we're looking at everybody. There's so much noise in the data. So if we focus using home and community-based services as an example on people with hip fracture, or with people who have hip fracture and ADRD, for example, and then we can really hone in on, here's a group of people with a specific set of needs. What is the best thing to do for that group of people?
It's a nice extension of sort of what we're doing, because we don't really get to that next step. Yeah.
Anything else?
There are two questions online.
Sure.
Go ahead.
Yeah, we can't
Sorry.
another thing, so chat.
I'm looking for the chat feature. If you have a question, please feel free to shout it out.
Anyone online with a question?
If you stop sharing your screen, you should be able to see the chat.
Oh,
Hit the escape.
oh, here's the chat. I'm sorry about that.
Hi, great talk. This is Hogan from the GRAC. I wanted to show your visual about comparing inverted weighting to the kernel weighting, and walk us through that one more time. I heard a few questions about the kernel weighting, so maybe, a couple more slides. There we go, this one. Could you just walk us through that, please? Thank you so much. Great talk.
Yeah, happy to. So the idea here is that we are trying to match our treatment and comparison groups on similarity of a vector of propensity scores. So the different types of shading here show the probabilities of receiving each of the 3 treatments. So if you're using something like inverse probability of treatment weighting, you're only going to match on one type of treatment. So you're going to see that you have a treatment and comparison group that have those similar levels of the pink shading at the top bar, but they might look completely different in their probabilities of receiving either of the other 2 treatments. In vector-based kernel weighting, we are using the entire vector propensity scores for our matching. So we're assigning weights to observations in the comparison group that have a similar probability of receiving treatments A, B, and C as the treatment observation.
So then you have to throw out people, out a lot of unmatchable individuals. I mean, I don't
Yeah.
understand actually, because I thought you were doing weighting.
Mhm.
Now you're telling me you're doing matching, so.
Yeah, it's a hybrid between the two. So what I should say is we are assigning weights based on bandwidth function. So we're going to give so yes, we will not assign a weight to observations that are outside of the bandwidth of the treated observations propensity score. And then within that bandwidth, we are assigning weights. So
They'll be excluding some.
yeah.
But we'll be excluding people with extremely low probabilities of receiving a particular treatment.
Right, so they wouldn't be the observations that you'd want to include probably in a comparison of receiving any of the three treatments because they're not, that's not possible for that observation.
There was one more question online, I think, or one more comment. Alan?
The question is about including comparisons against machine learning algorithms, such as boosting. We have not compared against boosting yet. What we have done is compare against covariate balancing propensity scores. It's a semi-parametric method. What we found is that covariate balancing propensity scores improve the bias and efficiency of inverse probability of treatment weighting estimates. They don't actually improve the performance of vector-based kernel weighting. And vector-based kernel weighting continues to outperform inverse probability of treatment weighting when it's used with covariate balancing propensity scores.
Were there any other questions or comments? And then we'll close.
Hi, this is Zhixiang. That is a very nice talk. Could you comment a little bit on the selection of the bandwidth using the kernel-based weighting? Because I think there should be something tuning parameter we have to adjust for.
Yes, we use butcher the pronunciation, the Shednikov kernel. We've tested a variety of bandwidths. We use, I think, 0.4 times the standard deviation of the logit of the propensity score in most cases. We've tested sensitivity to a bunch of different bandwidths and see similar patterns and results. We're still trying to figure out how to make the optimal bandwidth though.
Yeah, excellent. Thank you.